Consultant pediatrician working in Winchester. I've been teaching students for over 20 years now, and what I've prepared are a series of 15 talks on pediatric teaching and training for students. They are very low tech, and they're not going to be the answer to how you are going to study everything you need to know to be safe and competent looking after children. But what I'm hoping is that I've given you a series of 15 short talks that give you a springboard from which to start thinking about your pediatric attachment. In each talk, I will speak for about 10 minutes on a particular topic that is really important for us. And when we think about unwell children or children that we might be assessing in a clinic or an emergency situation. I will try and highlight some of the things that I think are really important for us to be aware of, and some of the learning points and things I would like you to be looking out for on the wards and in your further reading. There will be far less in the way of information and facts, and you will need to go and read and talk and think and ask good questions to get anything like a thorough pediatric grounding. Rather, I will be concentrating on some of the ideas and principles and concepts that we use in pediatrics as a way of trying to think about the topic and introduce you to a topic that can seem very daunting and overwhelming at first. Children are not a separate species. They are small human beings, and everything that you know about assessing human beings and thinking about causes of their illness and treatment still is true. However, there are some things that are completely different in our approach to children, and these are the things that I'm going to focus on. The most important things that I think I would like you to think about throughout this series of talks are the following key points. Firstly, children change dramatically. They change both in terms of their size and shapes and proportions and normal physiology. They also change neurodevelopmentally in terms of what they are capable of doing for themselves, how they can communicate and how they can interact with the world. So if we're going to understand an approach to thinking about children, we have to have an approach to thinking about these changes. And I will be talking about neurodevelopmental assessment in a later talk. But I would like to start right now thinking about this idea of growth. Growth is obviously critical if you're going to get successfully through childhood. And we divide the growth of children into three phases. And I will talk about this in a little bit of detail later in this talk. However, the first two things I would like you to really think about today are the changes that you see in a child as they make the journey from newborn baby through to adult, and how those changes affect them both physically and neurologically. This will have a particular impact on the way that children present to us. They can't take themselves to the doctor. They can't bring themselves to the emergency department, and they can't decide when and how to go to the clinic. And they become increasingly less dependent on their carers, but a newborn baby is entirely dependent on their carer for all of their needs. And this is really important when we think about how we take a history. There is no point taking a history from a newborn baby, but a 17-year-old is going to give you 90% of the history and actually will be very offended if you don't talk to them and take the history from them, supported by their carers or the people that they choose to come with them. And so as we think about the history taking and we think about how we extract the information we need, both from the history and from the examination, and when we then start doing specialist investigations and start treatment, we have to be mindful of this as we think about the fact that there is not just one person in front of us. There is the person, the patient, but there's also the carer, and how we talk to that carer is going to change depending on the situation. That carer is not feeling unwell themselves necessarily, but will be deeply concerned for the well-being and the welfare of their child generally. They will therefore be wanting to ask questions. They will therefore want to be involved in decisions making. And the approach to the child and the carer is very different from the approach one might take in an adult patient who comes to you on their own or with somebody who's there just for support, but is not necessarily medical, legally and practically and emotionally so involved in the whole situation. Therefore, we've got to think about this approach when we're approaching the history and the examination and how we do tests and how we communicate. We've got to think about this in the newborn period, in the first few weeks of life, what we call the neonatal period, in the first year of life, what we call infancy. We've got to think about this in the preschooler and the toddler. And then we've got to think about this in the primary school age child, the secondary school age child, the adolescent, and the young adult. And the approach will have to change as they get older. Similarly, the things that they will present to us with will be different. The same presenting complaint will have a different differential diagnosis as you get older. So, for instance, a newborn baby with bloody diarrhea will have a different differential if they're premature or if they're full term, if they're bottle fed or if they are breastfed. They will have a different differential when they're a year or two older, when they're 6 years older, or 12 years older, or when they're an adult. And so we have to understand this different differential diagnosis. We have to understand that diseases and illnesses and problems will present at different ages. Everybody with type 1 diabetes presented for the first time clinically, and we have to be aware of how this might present in chronic illnesses such as diabetes or epilepsy. Every young person who has a syndromic diagnosis, every young person who has any form of long-term problem, whether it's Crohn's disease or Turner syndrome, will present for the first time. And so the way that we approach that first presentation is going to be really important. It's really going to drive the way we take the history and the examination, particularly in the first year of life, when all sorts of congenital problems might be presenting to us as clinicians. The differential diagnosis and the range of sorts of diseases that we might see in the first year of life are going to be profoundly different from 18 years later. And therefore, the way we might approach a child with a seizure, or a child with breathlessness, or a child with jaundice is going to change completely. And therefore, what we really need to do is think about how we approach these young people, not only thinking about their growth and their change and their neurodevelopment and how we interact with the young person and the carer, but also how we're going to get a relevant history that is pertinent to that child at their stage in their growth and development. We also have to have a slightly different approach to how we might resuscitate acutely unwell children. Physiology is going to change in terms of normal heart rates, in terms of response to illness, in terms of the sorts of illness that a child might get. The same virus that might give an adult a cold might cause viral-induced wheeze in an older child or bronchiolitis in a younger child. And we have to understand that the same viral illness might present in very different ways in different ages. And therefore, we're going to have to moderate the way we ask our questions and the way we think about our differential diagnosis. Finally, but really importantly, a newborn baby is, as I say, entirely dependent on their carer for their needs. They are entirely dependent for everything they need to thrive. And by thriving, I would think about the basic needs of any human being, their ability to get nutrition, to get fluids, to be kept warm, to be clothed, to be kept clean, to be kept safe from disease, and to be taken appropriately to healthcare or to social care or for education. These are all things that a child needs that they cannot get for themselves when they're newborn or in the first year of life. And some parents are not able, for whatever reason, to meet that child's needs. It may be that they don't have the necessary knowledge or education or financial ability to meet that child's needs without a bit of extra support. It may be that they've got their own health challenges, whether those might be mental health challenges or physical health challenges. It may be that there are other environmental or social pressures on this family, but it may also be that the parents are being deliberately neglectful of their child's needs for whatever reason. And we need to be mindful of this whenever we approach a child's care. Our duty is to our patient, and our patient is the child. And therefore, the safeguarding needs of that child are paramount and particularly pertinent in the younger child. In summary, what you're going to learn while you're on your pediatric attachment is how to think about a child's change through life, both in terms of their anatomy and physiology and growth and development. You're going to learn an approach to the history and examination and thinking about further investigations and treatment. You're going to need to think about the safeguarding needs of a child. And you're going to need to think about the changing differential diagnosis, both of the sorts of illnesses that they might present with, but also how they might present and with what illnesses and what presenting complaints and how that differential diagnosis might need to be formulated. This is obviously a huge potential range of things for you to need to learn, and we don't expect you to be experts in child health. But we do expect you to have this basic grounding and for you to have thought about and practiced and rehearsed and observed some of these key techniques. Finally, I'd like to just specifically mention growth. And as an outcome from this particular lecture, I need you to go away and have a look at a growth chart and think very hard about how pediatricians think about growth. When we think about growth charts, we are comparing the child in front of us with a population, and it is important that we understand what that population is. A growth chart will give us that child's position in the normal range of a range of children, and those children are of the same gender, healthy, and of the same age or corrected age if they were premature. It's an ethnically diverse range and it's an internationally diverse range. And what we're asking when we look at a growth chart is information in three domains: that child's weight, their growth, and for the younger child, their head circumference. In the older child, we then think about pubertal development as well. Whenever we're thinking about growth, we're asking ourselves three questions. Firstly, does this particular parameter fit within a normal range, or is it more than 2 or 3 standard deviations away from the normal? The further we get away from the normal range, the less likely that parameter is to be normal, and the more likely it is to be a problem. And therefore, a single plot on a growth chart might be sufficiently concerning for us to need to start further investigations. What is more useful, however, in pediatrics is trends. And if a child's weight or height or head circumference is trending away from the normal range in a way that is not the same as their peer group, then this is an important and concerning feature that we need to think about. Finally, we have to look at that parameter, but in the context of the rest of the child. We know, for instance, that a child who is losing weight in early childhood will then start to not grow their bones terribly well. And in an infant who is very malnourished, they may then start not growing their brain terribly well, and the head circumference will start drifting away from the centiles. We would then need to put that information in the context of the child in front of us and the rest of the history and the examination. We would then have to think, well, what is driving this problem? And there are really three main phases to growth in childhood. And we as pediatricians need to be aware of this. We need to be aware of the fact that there is a very steep rate of growth in the first year or two. And this is very much driven by nutrition. If a child is undernourished, they will lose weight and then, as I say, start to lose bone growth and height and length, and then potentially and very seriously and worryingly, head circumference. Similarly, a child who's getting more nutrition than they need may become overweight and may actually start growing and becoming taller and longer than might be genetically expected. Neither of these are situations that we would be entirely happy with as pediatricians, and we would want to think hard about them. The second phase of growth is a phase where nutrition is important still, But in the first few years of life, really up till the onset of puberty, a second and important feature that starts to come into play more is the hormonal influences. Derangement of the growth hormone axis, the thyroid axis, and the adrenocorticoid axis may cause significant problems with growth. And these can be manifest at any age, but we will start to see this sometimes in the second or third year of life or as the child is getting older. And we need to think about this. Finally, the third phase is puberty. And we may well see significant derangements in growth from very early, very late, or pathologically deranged puberty that may affect a child's growth. In summary, then, I'm going to be giving you 15 very short videos, much like this. I would like you to watch the videos carefully. I would like you to think about watching them again and making short notes, and then think very hard about what it is you need to go and do next to try and improve your understanding and learning of that topic. In this particular video, I've talked about some of the differences in children. I've talked about neurodevelopment, safeguarding, the changes in anatomy, in physiology, and growth, and how we think about growth. I've asked you to think about growth in terms of comparing the child in front of you on a growth chart with a normal, healthy age and gender matched population, and thinking about that specific parameter, the rate at which it's changing with time, and how it fits in with nutritional problem, a hormonal problem, or finally, we would think, is this a genetic problem, either a new genetic problem, such as a diagnosis of Down syndrome, or an inherited genetic problem, such as Marfan syndrome. Finally, we always need to be mindful of the fact that children come with carers and how we think about our history, examination, further investigations, and further treatment is going to be very intimately bound up with how we communicate both with the child and with the carer. We've finally got to think about that carer and that interaction with the child and whether there are safeguarding concerns and where these concerns might be arising from. I hope that by using this short series of 15 videos, you will be able to work your way through the very basic pediatric curriculum that we would anticipate any student to have a thorough grounding in before they start seeing children professionally after graduation.